Hello everybody, how you doing today? It's Adeleke, CEO, founder of Future Teaching Physicians. Thank you for watching all my videos. I want to say thank you for each and every one of you guys that have seen most of the videos we've made. We really appreciate your comments, and we're gonna make this big. This is just the beginning. We're gonna continue with the videos that we've been making on series on metabolic acidosis and alkalosis. Today I'm going to go over metabolic alkalosis. I know this is a very challenging area for a lot of students, and we're going to try to make it as easy as possible. Like I said, I appreciate your comments. I keep them coming. That's what gets me going. And before you know it, we're going to have a whole lot of videos coming for you guys. One more thing I want to tell you guys is always visit our website www.ftpinc.org, which is where you can find a lot more information about what we do, and this will give you a good idea where we are and where we're going with this. But thank you very much. Like I said, I'm still using Step Up to Medicine with a couple other resources, which, as time goes on, I'll let you guys know. So today, we're going to go over metabolic alkalosis. Like we always do, we start with definition. We kind of want to go over some pathophysiology. What is causing the problem? We want to know what the clinical features is, what the patient's going to present with. What is the diagnosis? What the lab is going to tell us, just a little bit. And how do we treat, right? If you don't treat, we're just basically wasting our time. So today's topic, we're going to go over metabolic alkalosis. I shared with you guys, if you haven't watched metabolic acidosis video, I implore you to go watch it. Click on the link down here below. I also want to implore you guys to go back, if this is the first time you're watching the alkalosis part of this series, go back and see the introduction to metabolic acid-base disorder in general. It will give you a better sense so that you're actually on par with me right now that we are starting this series. Like we always do, we like to cheat in medicine, don't forget about that. Our favorite formula. And I always told you guys, if you know this, just forget. This is the end from the beginning. This is the cheat formula. That's all you got to memorize, and you're always going to look like a star. I'm going to make an effort to repeat myself a little bit so that we can reiterate concepts that we're trying to get across to you guys. We always say, always write metabolic on top and respiratory at the bottom. Extremely important. That is gold. Okay? So what is metabolic alkalosis? It is metabolic. So it has to be something going on metabolically in your body in terms of how the body's pathophysiological processes are going on. Alkalosis, like we always say, is from the word alkaline. And from basic chemistry, if something is not acidic or neutral or basic, rather than saying basidosis, that doesn't sound too right. So we call it alkalosis, which means the pH has to be high. Very high. Remember, you have to memorize just a few key things that I'd written over. If you don't remember, we can just quickly just write on the side here. We said normal pH is 7.35 to 7.45. That's your normal blood pH. You don't want it to fall way too low or way too high. If it's going way too high, we go into the alkalosis section. If you're going way too low, hey buddy, stop. You're about to make me acidic. So automatically the pH is gonna be high, which is this guy right here. I try to make my videos a little bit more interesting, so we're gonna use more coloring in this video. We deal with pH. It's gonna be very high. So alkaline pH will be obviously automatically greater than 7.45. And what I will actually do and incorporate now into my videos is kind of like test questions. They're more like review cases to kind of get us, at the end of the video to get the whole point. So automatically the pH is going to be very high. But why is the pH high? We say it's alkalosis. alkalosis. That's a mnemonic we're going to talk about at the end of this, but let's get the concepts down cold. We're going to be dealing with metabolic. So right now, I do not care about the bottom. We'll talk about it because it's a compensatory mechanism, but that will come later. Metabolic means the pH has to be high. The only way the pH is going to be high is from bicarb. Bicarbonate is going to be elevated, and automatically, guess who's going to be lost? Oops, my fault. Hydrogen ions. Now, how does that happen? That is where the pathophysiology. Let's start with causes first, okay? Now that I kind of went over the brief review of this formula, now I want us to do something very, very easy. We're going to split our brain up into two. Oh, no, not that way. Don't do that. That's a bad idea, okay? We're going to break metabolic alkalosis into two parts. And this is a very tough concept for a lot of you. It took me a while to get a grasp of it, and I'm trying to kind of share this little secret with you. Medicine is all compartmentalization. If you split your brain into little sacs and put information in there, everything makes sense. You just grab a sack, you use it, you spit it out. People are like, wow, look at you, this guy is smart. Then you put it back in there, you screw it in. But if everything is all jumbled up, it's a mess. So, the key to metabolic alkalosis is urine chloride. I mean, this is big. I mean, this is serious. Urine chloride. I'm going to write it again. Urine chloride. I think the color sounds a little much better, right? Don't you think? So, there are two types. Saline-sensitive and saline-resistant. Saline from the word, saline is what? It's just salt. Sodium chloride. Every time we always tweak things around to make you guys, it's just a $2 word for salt. So, for saline chloride, we're going to start with what will be the urine chloride. So when I go to the bathroom and I pee, but I put a little cup in there and I measure the amount of chloride in there. If the chloride is less than 10 milliequivalent per liter, it's just telling me something. However, on the flip side of things, I did the same thing. Yo, dude, can you pee in the cup for me? Pee's out. I checked the urine chloride in the lab, and it's greater than 20 milliequivalent per liter. It's telling me something. What is that something? What will allow you to be able to retain urine chloride so that you're not losing it. So something is telling me this is definitely lower than this. So that means automatically this is less than 10, maybe around 5. There's not a lot of chloride in your urine. If it's greater than 20, you are peeing up heck of a lot of urine, don't you think? Let's see what's going to cause it. Causes of a saline, like I said, this is the, let's use green for this, saline-sensitive, and red, saline-resistant, metabolic alkalosis, and metabolic alkalosis. This is the bread and butter of metabolic alkalosis. So what's going to cause saline-sensitive metabolic alkalosis? Check this out. You guys are going to come to the emergency room. It's going to do something like this. What? I'm just trying to take a history of physical, and this guy just peeped on me, man. Why? What have I done wrong? It's like, Doc, I've been vomiting for the past 5 days. I'm like, damn, that's a long time, man. You still got the guts to come in and puke on me again? It's like, motherfucker, I'm sorry. I just can't hold anything down. What did I just gave it away, guys. The first thing that's going to cause is vomiting. That means anything that makes you vomit, anything. Like what? A 65-year-old guy's been using ibuprofen for the past 6 years, developed NSAID gastritis, start to vomit from the irritation of his stomach. He vomits so much. I'm like, oh, dude, come on, we should give him some prostaglandins to protect your belly. We didn't do that, we forgot. How about this? It's going to be a skinny chick. She's going to come in, She's about 16 years old. She's been trying to lose weight. Guess what the sister's been doing? She sticks a finger into her mouth every single day. She eats a little bit and she vomits all the time. She's going to develop metabolic alkalosis. That's it. That's one type of vomiting. If you develop any kind of gastritis, anything that causes you nausea and you vomit continuously, an alcoholic can come and start vomiting all over the place. Guaranteed. You're gonna. So people with bulimia, right? That was a lady. Or anorexia. Bulimia, anorexia nervosa, gastritis. But do you really need to memorize all this stuff? No. If you just know vomiting, that's all you need to know. It's gonna be another guy. Another way you can develop saline-sensitive metabolic alkalosis. I haven't talked about the pathophysiology. This is what's causing it. Diuretics. What is it? Furosemide, classic. Thiazides. They're gonna dry you up. That's where the problem is. But we're gonna talk about the pathophysiology so it makes a little bit more sense. But remember, vomiting, diuretics. Vomiting, diuretics. Now let's go over the pathophysiology, because that's where everything is going to make some sense. Remember, this is the left part of our, well, that's my right part of our brain. This is the left part of my brain. So we are working with the right inside of my brain right now to figure out what exactly causes saline-sensitive metabolic alkalosis. So the first thing that happens is the patient is going to vomit, right? There's little John with his mouth. Oh, he vomits, right? Not cool. Happens to the best of us. Once they vomit, what's inside our stomach, right? Let's see. Here's his mouth. Esophagus goes into the stomach, right? And the stomach, you got a duodenum. Then you got a little bit of the pancreas. Inside the stomach is a lot of what? Hydrochloric acid. The pH of the stomach is 2. I had a girl, I didn't see this. Actually, she got strangulated by somebody. This is not good. Up to the point that she vomits so much of that acid that the acid actually chewed up my face. It's pretty bad. But that's a sad story. I should have said that. But that's to show you how acidic the stomach is. So the first thing you do is you lose hydrogen chloride. You vomit it. So basically, the first thing that's lost is this. Hydrogen ions are lost. Excessive vomiting. However, you're also losing fluids. Right? Because when you vomit hydrogen chloride, you vomit for so long, you're losing extracellular fluids, volume. Now, what happens is, let's say this is the amount I've lost, right? I've lost a lot of hydrogen chloride, I've lost a lot of hydrogens, I also lost a lot of chloride, which will explain why my chloride is not going to be a lot in my urine to start out with. Now, there's not enough sensor, because you have to realize when you eat, the hydrogen chloride, which is the acid that goes into the duodenum, is what the pancreas senses like, oh no, we don't want a lot of acid inside the duodenum, because the pancreatic enzymes, the chymotrypsin, the lipase, you know that good stuff, that needs to come from the pancreas, they need to work in an alkaline environment. So automatically, once we lose all these hydrogen ions, there's no sensation for the pancreas to realize, that's cool. We ain't got a problem, you guys can go in. Then we retain the bicarb. Back to the formula. pH equals bicarbonate or hydrogen chloride over PaCO2. So what have we done? First thing we did, we lost this guy. We lost a lot of hydrogen chloride from vomiting. We retain so much bicarb because there's no sensor inside the duodenum for the pancreas to release the bicarb into the duodenum, so we retain them and they stay intracellularly in the plasma. Automatically, if the bicarb starts to go up, what will happen to your pH? Dun-dun-dun. pH goes up. So we develop metabolic alkalosis. But do you think that is really the end of the story? No! No! Automatically, once you start to lose extracellular fluid, volume start to decrease, we've got a problem. There's decreased perfusion to your kidneys. The kidney is going to be like, geez, I'm not getting enough fluids, right? And this is going to drive you crazy because why do you have to always go back to where we started? The kidney is sitting there and not getting enough perfusion, right? There's not enough blood flow to the kidney because you've been vomiting so much. So automatically, what happened? Decreased perfusion to the kidney is going to sense what? Say it, you know it, you and I both know it. It's going to stimulate renin. The renin is going to be released. The renin is going to stimulate the angiotensin 1. Angiotensin energy is going to be converted to angiotensin 1. Angiotensin 1 is going to be converted to angiotensin 2 inside your lungs. And angiotensin 2 is going to do what? It's going to vasoconstrict. It's going to do what? It's going to go into your glomerular capillary and vasoconstrict the efferent arteriole so that you can increase your GFR to the kidney. But it doesn't do that. That's not enough. It's also going to stimulate aldosterone. Aldosterone, that is the key. Aldosterone is exactly where we're going with this. So automatically, decreased ECF will stimulate the renin angiotensin 2 aldosterone system. That will stimulate aldosterone to be released. And you guys know what aldosterone is going to do, right? I know. Aldosterone is going to go into the distal convoluted tubule. It's going to increase sodium reabsorption back into the body. But the problem is the dude doesn't care about the potassium, so you're going to be losing potassium. So you're going to lose hydrogen ions and potassium. Now let me explain this concept very well. You're losing a lot of potassium because the way aldosterone works, it reabsorbs sodium and loses potassium. Now, when I talk about this side, when aldosterone is going haywire, we're going to actually understand why you're losing both of these guys. But for now, what will happen if you lose a lot of potassium? You develop hypokalemia. Hypokalemia. And also, because you vomited all your chloride, your urine chloride is going to be low. So let's recap. What will be the end result? I vomit, right? I lose all my fluids. I don't get enough perfusion to the kidneys senses, aldosterone kicks in, I lose potassium. So how do we end up with this story? We call it hypochloremic, which means I vomited all my chloride out, so my chloride is low. Good? You get that? Hypokalemic, because down in my kidneys, I lost all my potassium because aldosterone is like, bam, kick it in, out the potassium is bringing out the sodium. Because why are you bringing in the sodium? You want to retain extracellular fluid volume. Because you're losing a lot of fluids, it's called extracellular fluid contraction. Because you contract, but you don't want to lose too much fluid because you get dehydrated and it causes a lot more complications. Now, you develop hypokalemic metabolic alkalosis. How does that sound? So, let's erase this because you probably heard that before. I did too, but I didn't know why. Now you do. Isn't that cool? That's what I do. I try to figure out the whys so it makes some sense. So at the beginning we said the urine chloride is going to be low. That's how you're going to know. You look at the labs, you're like, geez, this guy's hypochloremic because his urine chloride is low. Well, he vomited it out. You look at the lab, he's hypokalemic. His potassium is like 2.5. It's pretty low. So we call it hypokalemic, hypochloremic metabolic alkalosis. That is cold. But you know what? If you can't even remember that, because it's tough sometimes. I remember I used to like alkalosis, alkalosis. This is crazy. Whenever you hear alkalosis, if you just kind of look at the way the word is actually spelled out, and actually I'm going to put this in red so you can actually see. Sometimes people can't see the trick I'm trying to pull here. Okay? And low. Did you see that? So when you have metabolic alkalosis, the potassium is going to be low. That is mine. Do not steal it. I came up with that idea. Alkalosis. So you're going to develop hypokalemic. Well, the chloride, you just kind of have to remember that, but I already told you about the pathophysiology. Hypochloremic, hypokalemic, metabolic alkalosis. Does that make some sense? Perfect. What is going to cause it again? You're going to be vomiting. You're going to be using a lot of diuretics. Now we're done with the right. Let's go to the left, to the left. That's right. Now let's go to the left hand side. Urine chloride, very high. What is going to cause your urine chloride to be Do you want us to talk about treatment? No, we'll talk about treatment last because we always go pathophysiology, clinical features, diagnosis. So we figured out the diagnosis of this guy. Urine chloride, extremely resistant. What will cause this? The most common cause of urine chloride saline-resistant metabolic alkalosis is hypoaldosteronism. Where's aldosterone coming from? Let me see. I might not remember, but I'll tell you exactly what. No, I do remember. It's coming from the adrenal cortex, right? It's coming from the adrenal cortex. So we're talking about a kidney problem here with the little ice cream of the adrenal gland, and it's making too much aldosterone. It could be bilateral adrenal hyperplasia, or it could just be an adrenal adenoma, just spitting out all this aldosterone. Before I go into that, this is endocrine, sort of, kind of. Too much aldosterone will cause what? Let's see. That means aldosterone is too high. Right? That is the key problem. So what I'm going to do is, this guy is going to come from here. Let's go into the kidney. Kidney looks something similar like this. It's actually nephron. And you go into the thick ascending loop of Henle. And eventually you go here. And then you come down to the distal. Then you have the collecting duct. And remember, there's a bunch of tubules here. To make it a little bit more colorful, we're going to use some nice color. Let's use the tubules pink. These are the renal tubule cells. Beautiful, cute little things. And on the other side of town is our blood vessel. I don't know why I use green, but it'll work. So, right at this junction is where the main action is. That's the business end. Aldosterone, normally, it causes you to retain sodium and lose potassium. If you have too much of it, what it's going to do? It's going to create a lot of pumps here, and you're going to be reabsorbing a lot of sodium, but guess who's going to be lost? A lot of potassium. You're going to be literally losing, so you become hypokalemia. Are you digging that? Good. You're losing a lot of potassium, causing hypokalemia. You're reabsorbing a lot of sodium. Also, you're retaining a lot of bicarbonate. So, patients with hyperaldosteronism, they're going to have hypernatremia, which actually is going to be mild, maybe like 146 or something. There's a reason why you actually don't develop severe hypernatremia, because the atrial natriuretic peptide inside your heart is going to see there's too much sodium being reabsorbed, like something's got to be going on. So it's going to release that, that's going to go into your kidneys, so you pee out some of the sodium, so you don't get way too much hypernatremia, which is going to cause you to get seizures, and you're going to have some big problems, right? But, so, I'm just going to dive right into endocrine a little bit. So you develop hypernatremia, which is kind of mild. You develop hypokalemia, because you're losing a lot of potassium. Now remember, the last time I was talking to you guys, I was like, oh, we're going to go over why you're losing both hydrogen ions and you're losing a lot of potassium. So we're going to think of it this way. This is the back of your house, and this is the front of your house. There's a little drainage in front of the house. That would be a blood vessel, right here. And this is inside your cells. Now, because there's too much aldosterone and you're losing so much potassium, the body will be like, something is leaking at the back of the house. All the potassium is going through the bathroom and just flush down the drain while we need them. So these cells are going to try to release potassium to replace, because remember, if you don't have potassium, you get hypokalemia, you get the flat waves, the U waves, and no, you get a cardiac arrhythmia, you get torsades de pointes, and you get ventricular tachycardia, ventricular fibrillation, and people can die. It's pretty bad. So the body automatically starts to shoot out potassium into your blood vessels. But in exchange for that, hydrogen ions are going to start what? Being pumped in. A lot of hydrogen ions are going to be exchanged for this potassium. However, what will eventually happens is these hydrogen ions are going to get kicked out on the other side. That's exactly what's going to happen. So you're losing a lot of potassium, and then you start losing a lot of sodium. I'm sorry, but hydrogen ions. So what that brings us back, try to create some space here. We don't really need this part of the diagram. This is saline-resistant. So automatically, what you're going to see from our formula is this. We said bicarb hydrogen ions over PaCO2. Correct? That means we're losing hydrogen ions again. We're back to the same thing. We're losing, but it's a different pathophysiology. See how the pathophysiology is different? We're losing a lot of hydrogen ions and we're retaining all this bicarb, and at the same time we're retaining a lot of sodium. But that will also cause us to keep our pH very high. On the flip side of things now, we're losing all the potassium, so we're still going to develop hypokalemia, metabolic alkalosis. But in this case, we're also going to be losing a lot of chloride. A lot of chloride are going to be being pumped out from the tubules, and that's what's going to cause your urine chloride to be very, very high. Because you can only retain the sodium, you lose a lot of chloride. Remember, normally sodium chloride should be reabsorbed, but because you're making way too much aldosterone, you can only reabsorb so much chloride, so eventually you're going to be losing them back into the urine, and you start to pee it out. So that's where the urine chloride is very, very high. I hope you kind of got that concept. Too much aldosterone. So let's kind of recap. Too much aldosterone, you reabsorb a lot of sodium, right? You're holding on to the sodium, you're holding on to the sodium. So the volume is what? Expanding. That's why they call it volume expand, ECF, which is extracellular fluid level expansion, compared to extracellular fluid contraction, because you're vomiting here. In this side of the building, aldosterone is what's causing the problem. You retain so much sodium, you try to hold on to a lot of water, but you lose a lot of chloride in your urine, which causes your urine chloride to be very high. What will happen is you're also going to lose potassium, because aldosterone is going to cause you to lose potassium and hydrogen ions, which we kind of talk about the intracellular exchange mechanism of way too much. When you have too little potassium being lost inside the tubules, this cell's trying to secrete this, so you're still hypokalemic, because you're going to lose a lot more than you think. because this is just a compensatory mechanism. But hydrogen ions always exchange for potassium. So this hydrogen ion is going to be pumped into the peritubular capillaries, right down to the tubules, and bam, you become hypokalemic metabolic alkalosis. And the alkalosis is because you're also losing these hydrogen ions. And where did they come from? They are being exchanged for potassium. So you get alkalosis, mild hypernatremia, you get a little headache, polyuria. Why? Because you're going to be peeing your brains out. You're losing a lot of chloride. Although you try to reabsorb you try to hold on to a lot of sodium, but eventually you're going to also be losing some sodium eventually, which causes you to pee out a lot. But that's just endocrinology. But the main concept here is to see where this hydrogen ion is being lost, which causes you to retain a lot of bicarb. So once you lose this, you retain this, and your pH goes up automatically. That's the number one cause of saline-resistant metabolic alkalosis. What else can cause this? This is not a common disease, but you probably heard it on your boards in medical school. Bartter syndrome. Crazy, right? Let's go over that real quick. Bartter's is another cause of saline-resistant. This is a very complicated topic, so I'm trying to go as slow as possible so you can grab the concept. Bartter syndrome is actually just like using a diuretic. Remember from renal physiology, you got a proximal convoluted tube going down to the thin ascending loop of Ehrlich. The thin ascending loop of Ehrlich is going to bend and become the thick ascending loop of Ehrlich. Look how big that is. In this junction, this is where you get the sodium potassium 2 chloride co-transporter. And also in this junction is where calcium and magnesium is being absorbed. Some people, we don't know why, can automatically develop the inability to reabsorb sodium and chloride. So if you can't reabsorb this sodium and this chloride, we've got an issue, right? Don't you think? So they start to lose a lot of what? Sodium and chloride. That means there's not going to be enough sodium chloride, reaching this area of their body. I'm sorry. You're going to lose a lot of this sodium and chloride, and once you lose that, what do you think is going to happen? It's basically you're peeing out a lot of sodium. You're losing a lot of fluids. What the body's going to do automatically is going to sense aldosterone to be released. And once aldosterone is released, aldosterone will do what again? It's going to reabsorb sodium, you're going to lose potassium, right? You become hypokalemic, and once you lose, when aldosterone starts to act again, you lose the hydrogen ions, and once hydrogen ions lose out, you lose hydrogen ions, you retain bicarb, your pH goes up, but you're also losing sodium and chloride. And because you're losing so much sodium and so much chloride, look at that. Urinary chloride is going to go up. Just to make sure I'm not missing anything, because I kind of took some little notes here for you guys. Let's see here. I think we pretty much covered that. So, Bartter syndrome, right? It's just basically inability of the kidney, thick ascending loop, to reabsorb sodium and chloride. You lose so much sodium and chloride, which is going straight to your urine, because you're peeing so much out. The renin-angiotensin is going to develop again because of decreased perfusion to the kidney. Aldosterone kicks in. When aldosterone kicks in, you lose the potassium, you lose the hydrogen ion. When the hydrogen ion is out, bicarb goes up, pH goes up. Get it? Perfect. That is pathophysiology in short. Now, let's talk about treatment. We've diagnosed these patients. They're going to come in. They're going to have the symptoms. The symptoms are going to be vomiting. In case of urine chloride sensitive, in this case, they're going to have an endocrine looking like syndrome, like headaches, polyuria, weakness. Oh, doc, I'm just weak. Why are they weak? Because they're losing so much potassium. That's why I kind of go over the pathophysiology before we head over to how we diagnose this patient. Patient says they're weak, you check your harder labs, and bam, their sodium is slightly high, their potassium is a little bit low. You kind of tell their blood pressure is actually elevated. You're like, man, that sounds like the adrenal gland is doing something wrong. Check the renin-aldosterone level. aldosterone is going to skyrocket high. They're running aldosterone level. You know that is a problem. And automatically, how do we treat hypoaldosteronism? Two ways. If it's one gland, it's just acting up, blue buddy, what do? We take it out. Surgically, it's called unilateral adrenalectomy. So, I'm going to erase this. This is actually step 2 material, but hey, you know what? You have nothing to lose. So if it's just one gland, and there's just this little gland, we go in there, we cut it out. That's called unilateral adrenalectomy, which is just a fancy way of saying we went in there and we cut out the little adenoma. If it's two, if it's bilateral adrenal hyperplasia, which means you've got two clones and the entire gland is acting up. What do you want to do? A guy comes in, you diagnose him with primary hypoaldosteronism. You really gonna go in there and take both adrenal glands out? This guy's gonna go to crash, right? Because then he can't maintain his blood pressure. He's gonna go to hypertensive and he's gonna die. So we don't do that. We're not gonna cut this out because this is hyperplasia. What do we treat it with? Spironolactone. Right? Block the receptors. If you block the receptors, yeah, you know what, slow everything down. That's how we treat that. One thing you have to understand about this side of our brain that we're talking about, which is the urine chloride resistant, is that it doesn't respond to extracellular, to normal saline. How do we treat this side? They lost that too much fluid. You give them normal saline back. So when they ask you in the hospital, patient has hypokalemic metabolic alkalosis, doc, just get them 0.9 normal saline. Is that enough? No, it's not. Alkalosis. Alkalosis. They've lost the potassium. Give them potassium back. That is how we treat saline-sensitive. Because it's sensitive to saline. So we give it saline back. Good. I like that. It's pretty straightforward. You know what? There's something in medicine. You come in something and missing. You know what? We put it back in. You go home. You feel good. And you see it. It's not there. You put it back in. You fix it. Everybody's happy. Okay? Cool. All right. So we've talked about metabolic alkalosis. I know this is a little challenging concept for a lot of people, but if you think about it, it's actually straightforward. On my right-hand side, we are vomiting, and we're using diuretics. On my left-hand side, we're using aldosterone. It's too much aldosterone. And the aldosterone is causing too much problem. Don't worry yourself about Bartter syndrome. Your odds of seeing that in the hospital is very low. Most people will come in with too much aldosterone because they have an adrenal adenoma or bilateral adrenal hyperplasia. Or, do you think everybody vomits? Yeah. Always remember medicine. The most common things are common. Don't sit there and try to memorize things that are not as common, because when you become an intern, and if you're a first year medical student, if you're a nursing student, you know, whatever area of medicine you are and you are learning this information, think the most common first. Once in a while somebody will come in, throw a little curveball. If you're smart enough and you know the pathophysiology, you might be able to track them down. Okay, on this note, I want to thank you for watching this video. If this is helpful, click the like button. I like this because this is what gets me excited. This is what allows me to keep making these videos. Check out our website, www.futureteachingphysicians. Actually, that's the name of us of my site, but it's ftpinc.org. And that's where I'm going to be putting up a lot of my videos. Before you know, we're going big. You guys have requested a lot of videos, and I'm going to be making them for you guys as soon as possible. I want you to review this information again. We're going to be going over respiratory acidosis in a few minutes. Come back, check us out, search us on YouTube, and stay blessed. God bless you. Have a good day. Bye-bye. Till I see you again. Future Teaching Physicians, making medicine ridiculously simple and accessible. Mercy. Adios.